This is Lab Medicine Rounds, a curated podcast for physicians, laboratory professionals, and students. I'm your host, Justin Kreuter, a transfusion medicine pathologist and assistant professor of laboratory medicine and pathology at Mayo Clinic. And today we're routing with Dr. Wysokinska, an assistant professor of medicine and consultant in the Division of Hematology and Oncology at Mayo Clinic in Florida, to talk about clinical updates in thrombotic thrombocytopenic purpura, so what we often call TTP. Thanks for joining us today.
Thank you for having me over.
Oh, this is a great time. So for our audience, it's been about 10 years since we trained together, and this is a nice reunion experience for the two of us to talk through. And actually, we're talking about something that the two of us deal with, and I'm kind of wondering if you kind of help us set the stage for our audience, because they may not be dealing with TTP, and so if you could maybe give us a starting point for kind of what is thrombotic microangiopathy, and how does that fit in, or how does thrombotic thrombocytopenic purpura, gosh, a lot of mouthfuls here, how does that fit into this category?
So because of the mouthfuls, I may just resort to using the kind of the abbreviations that we use. So TMA for thrombotic microangiopathy, and then TTP for thrombotic thrombocytopenic purpura. So these are disorders. Really, they're disorders of clotting. They're disorders of the blood and of the immune system. So really, what thrombotic microangiopathy is, it's a finding in the blood where you form small microthrombi in small blood vessels, which leads to ischemic changes. Concurrently, because of these microthrombi, you see specific changes in the blood on the blood testing. One of these kind of the classic finding is microangiopathic hemolysis, which specifically means finding of schistocytes. Schistocytes are sheared red blood cells. So when you look under the microscope, normally you see these now nice round red cells shaped like a donut, but schistocytes really look like red cell fragments. They're like little pieces of the cell floating around. And when you see multiple of these schistocytes, we call it microangiopathic hemolysis. Generally, concerning finding is when you see at least two of these in high power field, but overall, you should start kind of questioning if you see any of them. And concurrently, because of the consumption of clotting cells of platelets in these microthrombi, you also see decreased platelet count. So classically, TMA will give you this microangiopathic hemolysis and low platelet count. Now, the microthrombi, generally, it's not something you will see. The findings in the blood are indirect evidence of these microthrombi in the blood vessels, but as it often, for example, affects organs such as kidneys, on kidney biopsy, sometimes you can see these TMA, these microthrombi, and that's kind of the pathological finding that you will see. And thrombotic thrombocytopenic purpura, TTP, is one of the subtypes of the TMA. And it's one of what we would generally call maybe a primary TMA, in that there is a very specific abnormality associated with this and very specific treatment. TTP occurs when there is a defect in a special enzyme called ADAMTS13. It's one of the metalloproteinases in the blood. What ADAMTS13 does is it breaks up von Willebrand factor multimers. And I may kind of go back a little bit to explain kind of what they do, right? So when first your body forms a clot, one of the first kind of elements, one of the first stages of clot formation is when platelets attach to von Willebrand factor multimers, right? And von Willebrand factor multimers normally are coiled up in the blood. They're large proteins. They open up, and the platelets attach to them, forming a clot. So ADAMTS13 keeps the von Willebrand factor multimer is the right size, so to speak. It cleaves them into these smaller kind of active pieces. Well, when you don't have enough of this enzyme, which is the primary problem in TTP, you form these ultra large multimers. And what they do is the platelets, they actively kind of catch the platelets attach to them, which leads to these strings of these clots in the microcirculation, which ultimately leads again to the microthrombi. The strings, the red blood cells, when they flow across these small blood vessels, they shear up. That's why we see the schistocytes. And that's how you run into problems with TTP.
I really appreciate that for our audience, right? We have a diverse audience of laboratory professionals, clinicians, and students. And I think probably for some people, like TTP has kind of been something that maybe they learn about in school because, as you're saying, it's kind of a characteristic. But I really appreciate how for our audience you kind of took that dive into that to explain what do we mean, like what is happening for patients in this condition. And I love that you're showing like that's why, like why are we seeing schistocytes or sheared red blood cells is because of this idea of having these strings and clots that are just cutting these almost like, I don't know, what is it, like a cheese grater or something like that, cutting these red cells into pieces, and then we see these fragments when we're looking at the peripheral sphere. So it's really kind of helpful, I think, to unpack that a little bit for the audience. So I guess what, from your perspective and as an expert that treats this, like what's important for the, laboratory professional, student, and clinician to appreciate it about TTP. So, I mean, obviously, it's given during medical school as kind of a characteristic disease, but in practice, what's the important thing to know about it?
Yeah, no, it's a very good question. And I think, because TTP without treatment carries such high mortality, right? It's 80–90%. So we always have it on our radar. And I think we always kind of watch for these schistocytes on blood smear, especially if a patient presents with low platelets and hemolytic anemia, where, either the laboratory testing reveals that there is hemolysis, low haptoglobin, elevated LDH, or somebody from the lab calls you to let you know, hey, I'm seeing schistocytes on the blood smear, or it's reported kind of in laboratory tests. So I think just keeping that on the radar as a potential diagnosis. I do think in our kind of experience seeing very diverse patient groups, transplant patients, patients with also other TMA syndromes like atypical HUS. In practice, probably most patients that we see with schistocytes don't have TTP. And nevertheless, it's always that syndrome that you have to rule out, that you have to act on, and you have to act on relatively quickly. So I think just keeping that on your radar, knowing that that's a possibility, is extremely important. And generally, we always appreciate a call from the lab because usually the lab is the first line, that the smear is abnormal, there's low platelets, right? There is the hemoglobin, those always gets reviewed. We appreciate a heads up and from the lab team to let us know that they're seeing something concerning, specifically schistocytes. Because clinically we definitely want to know about it. And then it's so important to know because the treatment has to be instituted very quickly. And that's when you come in, I think, when we ask you for help, because TTP is caused by deficiency of this ADAMTS13 enzyme. And obviously it can be genetic. You just don't have a gene to produce kind of good, adequate ADAMTS13, or more commonly, you developed an antibody immunity against this enzyme, and you're attacking it in a sense, and you don't have enough levels. So the primary treatment is to replace, right, the ADAMTS13, and also kind of to remove the antibody, and that's where plasmapheresis comes in, right? So it's very kind of important to get that started quickly because that's standard of care. We will talk maybe later on that maybe not for the long future, right? Where we're soon going to have these additional treatment options that may replace plasma exchange, but still right now, obviously, it's still very important to institute that treatment, and that involves calling your blood banker, or I think in different centers it may be, I don't know, nephrology who runs the plasma exchange, hematopathology, sometimes hematology kind of runs the plasmapheresis. So you have to get that started, get the line in, and get the treatment started quickly, in addition to trying to eradicate the antibodies. So I would say the vigilance, that's one thing, and two, knowing what to do once you have suspicion that it's TTP, and also obviously sending the laboratory testing for ADAM-TS13.
It's so important. So I think top of mind hearing that, 80 to 90% mortality, right? I mean, that just sends off alarm bells, and also I think reinforces why is it a characteristic thing that we're talking about. So, just what it can mean to a patient's life in terms of losing it. And the idea you talking about the importance of initiating very rapidly something like plasma exchange, plasmapheresis to treat the patient. So this isn't something that like, let me sleep on this and cogitate, and maybe after then this is something that needs a little bit more of an urgency to it. I also like that you kind of highlight the vigilance of thinking about it. I wonder, maybe for our audience, are there some some common things that you mentioned, like we see transplant patients that might have a thrombotic microangiopathy. So, Dr. Vincent Scott, is there a way that you sort of might rule out or decide, oh, I'm concerned about TTP, but are there some common ways that you're kind of ruling it out? What do you
Yes,
do there?
absolutely. And thank you for that nice question as a segue into the plasmic score. So
Mm,
there are prediction tools that we can utilize to kind of predict, to define how likely it is that our patient with TMA does have TTP. And so there are actually a couple of prediction models. I think the one that probably we use the most is the plasmic score, which
mm.
is based on very specific clinical questions that help you kind of narrow down, is this the patient you think that may have TTP? And I think it's about 6 questions or so total that take into account exactly, is this a transplant patient? Does this patient have malignancy? What is their kidney function? Do they have laboratory findings that support that there is a hemolytic process going on? It takes into account actually patient's MCV, so whether it's low or not. So based on that, you kind of add these points up and you come up with a score. And if the score is 5 or higher, it kind of puts the patient into that intermediate higher risk category where you think, yes, I should pull the trigger on on the management, right? Or on starting plasmapheresis, on starting immunosuppression. Additionally, as part of evaluation, obviously you want to send ADAM-TS13 testing, which once it's back may help you guide the next step. Do you need to continue with plasmapheresis? Is it really TTP, or is it one of these other processes? And then you can back off some of these more intense therapies like plasmapheresis or other treatments.
So as I hear you there, it sounds like the plasma score, and I think we can link to that in the show notes for listeners. But it almost is functioning the way I guess I'm thinking about, like a lot of people might be used to the 4T score for thinking about HIT or heparin-induced thrombocytopenia. And I guess, would you kind of think of the plasmic score as a similar thing, as a tool somebody can use to kind of evaluate the likelihood that they have TTP?
I think so, and with kind of the newer ISTH guidelines that maybe updates at the recent ISTH meeting, I do think that probably will be definitely incorporating it more, and it's definitely something we utilize in our clinical practice. So yeah, I think definitely a big part now of the initial assessment of these patients.
Right on. And so how are things changing, and what's kind of evolving in the practice of TTP?
Yeah, so exciting things are happening. I mean, we talked about right plasmapheresis, which is a great way to kind of remove the antibody and replete ADAMTS13, but it really increases the level of the enzyme to the safe levels, and that the whole microthrombi process stops, but still the level kind of remains low, and we know. For patients with TTP long term, those that have the thrombotic process is controlled, they have normal platelet count, but even if they kind of remain at low ADAMTS13 level, they tend to kind of have more cardiovascular thrombotic complications later on. So there is something about controlling the acute process, but also long-term consequences for these patients that we're now finding out may be tied into the ADAMTS13 level by itself. So there are some kind of novel therapies that are coming out. One of these is recombinant ADAMTS13, which was FDA approved, kind of I think in late 2023 for patients with congenital TTP. So those that have a defect in ADAMTS13, there's over 200 of these multiple mutations identified. That lead to this process. It's a very rare disorder, so these are not huge clinical studies. Nevertheless, patients treated with this recombinant ADAMTS13 in a prophylactic and on-demand treatment had very nice responses in treatment of these acute TTP episodes and in reducing the risk of them having any acute TTP events. So this is a very exciting kind of a novel treatment options for these patients. Also, I do believe around May 2024, there was a case report also in New England Journal of Medicine of utilizing this approach in a patient with acquired, so with more common immune TTP, which is what we see more commonly, right, in our practice. This is autoimmune TTP with development of this ADAMTS13 antibody. It was a patient that was refractory kind of to standard treatment options, plasmapheresis, plasma exchange, steroids, immunotherapy, caplacizumab, which we'll touch on shortly, that responded really well to kind of this compassionate use of recombinant ADAMTS13. So I do believe there is a clinical trial now looking at this as a kind of a standard option in addition to plasmapheresis and immune TTP. So we'll probably have evidence in the near future that it can be used upfront, and it might be in the future used instead of plasma exchange for these patients. So that's kind of an exciting development with TTP. Additionally, a drug called caplacizumab, which has been approved for a TTP for a while now. And I think there is still a little bit of a debate in its role up front. When you look at the guidelines from International Society of Thrombosis and Hemostasis, it is suggested to be used up front in all patients with a TTP. It is given just before starting plasma exchange and then afterwards for about 30 days total. It does reduce the duration of plasma exchanges. It helps with some of the kind of the risk of certain complications. There is some evidence that maybe it reduces risk of death in certain kind of meta-analysis. It is, however, relatively expensive, not available everywhere, and there is a slightly higher bleeding risk. And what actually, maybe I should explain that what caplacizumab does is it blocks the binding of von Willebrand factor to platelets. So as you can imagine, that's kind of what we want because that's what's causing the problems. But by itself, it also increases bleeding risk. So there is that seen in clinical studies with very rare cases of serious bleeding. So I think there is concern justifiably sometimes about using caplacizumab up front. And I think we're still working maybe on refining where should we be using it. And I think certainly in patients who have quite pronounced neurological symptoms, when you worry about CNS ischemic changes, severely ill patients, I would certainly think in a patient who previously had a stroke related to TTP and now they have a relapse, that's certainly, caplacizumab, this drug would be used up front. And also, there is an ongoing clinical study also looking at it instead of plasma exchange. There is certainly case reports from Europe, even large case series in patients that did not want plasmapheresis, patients that could not have plasma exchange due to religious beliefs, where just using caplacizumab to prevent kind of the formation, to prevent the binding of Willebrand factor and platelets, while there's that in the background, rituximab is used and steroids to eradicate the antibody. That is actually fairly effective, and these patients have done well. So a large study is now ongoing, multi-center, where caplacizumab can be used up front as a kind of instead of, as a backup with plasma exchange for patients with TTP. So a lot of kind of exciting developments with these new options.
Yeah, it sounds like there's a number of tools coming out. And, it also sounds like, because classically it's just basically been plasma exchange for patients. If there was any delay starting plasma exchange, the classic teaching was you would do a plasma transfusion until somebody could get exchange. But it sounds like with these new tools, and what I'm hearing you saying is that in the coming years, we're going to get a fair amount of sophistication of, I guess maybe that's my kind of, to wrap this up, question. It sounds like we'll be getting more sophisticated. Do you think at some point we might be kind of realizing maybe there's subtypes of TTP and why this patient maybe, would be treated well with caplacizumab, or like that case report, this patient is going to be doing well with the recombinant Adams TS13?
Yeah, I think that's a great point. Yes, I mean it's a relatively rare disorder still, so it's great that we have these multi-center studies. And I think, they're looking at a lot of parameters exactly to better refine which patients would best benefit from each approach. So yes, and I do think that now we're kind of refining, right, the treatment upfront based on the plasmic score, but also based on the Adam TS13 level, based on the kind of the clinical presentation. So I definitely can see in the future how, because we're going to have these, so to speak, the abundance of different options and different approaches where there would be a role for very individualized management. I think that's going to be very exciting.
We've been routing with Dr. Wysokinska to talk about clinical updates on TTP. This has been a wonderful reunion for me. Thanks for joining us today.
Likewise.
And to all of our listeners, thank you for joining us today. We invite you to share your thoughts and suggestions via email to mcleducation@mayo.edu. If you've enjoyed this podcast, please subscribe. And until our next rounds together, we encourage you to continue to connect lab medicine and the clinical practice through educational conversations.